Hello everyone. Today's topic is about headaches. Prevalence of headaches. Headaches are one of the most common problems presented to physicians. They are painful and debilitating for individuals, an important cause of absence from work or school, and a substantial burden on society. 47% of adult population experiences headache at least once per year. Primary headaches constitutes 90% of cases. So according to this picture, uh, the tension headache is the commonest type of headache, 78% episodic tension headache. And then following this is episodic migraine, 16%. And then chronic daily headaches and all types, around 4%. Pathophysiology of primary headaches. Migraine is thought to be a neurovascular pain syndrome with an altered central neuronal processing, activation of brainstem nuclei, cortical hyperexcitability, and spreading cortical depression, and involvement of the trigeminocervical system, triggering neuropeptide release such as calcitonin gene-related peptide, VIP, vasoactive intestinal peptide, substance P, which causes painful inflammation in the cranial vessels and the dura mater. And this is another picture of, the theory beyond migraine headaches. And basically, it's a neuroinflammatory and vascular phenomenon. I add to this, okay, a myofascial component. All right, so it's not only a neural and vascular and inflammation. It's also there's a myofascial component. And as you can see, these are the central important pain processing parts in the brain here, starting from the trigeminocervical complex to the thalamus, hypothalamus, cortex, and upper cervical nerves, releasing the calcitonin gene-related peptides and other inflammatory mediators. This is a schematic representation of the trigeminal nerve. As you know, the trigeminal nerve is composed of three nerves: ophthalmic, maxillary, and mandibular. Okay, and by the way, the mandibular has not only sensory, part here. It has also a motor, nerve fibers coming from the motor nucleus of trigeminal. Classification of headaches. We have primary headaches or idiopathic headaches. These are the commonest types of headaches. The headache itself is the disease, no organic lesion in the background. Secondary headaches or symptomatic headaches, the headache is only a symptom of another underlying disease. So you have to treat the underlying disease. The International Classification of Headache Disorders, 3rd edition, ICHD3, 2015, has classified headaches into 14 components here. First is migraine. Second, tension headaches. Third, trigeminal autonomic cephalgias. 4 is other primary headache disorders. 5 is headache attributed to trauma. 6 is headache attributed to cranial or cervical vascular disorder. 7 is headache attributed to non-vascular intracranial disorder. 8 is headache attributed to a substance or its withdrawal. Number 9 is headache attributed to infection. Number 10, headache attributed to disorder of homeostasis. Number 11, headache or facial pain attributed to disorder of cranium, neck, eyes, ears, nose, sinuses, teeth, mouth, or other facial cervical structure. Number 12, headache attributed to psychiatric disorders. Number 13, painful cranial neuropathies and other facial pains. 14 is other headache disorders. Again, common causes of headache. Tension headache, 69%, migraine, 16%, and then others, okay? As you can see, secondary headaches, the commonest thing in the secondary headaches is basically systemic infection. Then you have head injuries, vascular disorders, subarachnoid hemorrhage, and brain tumor. But again, the commonest type of headache is the primary headaches. And the commonest type of primary headaches is basically tension headache. Headache symptoms that suggest a serious underlying disorder. The red flags of headache. So, like low back pain, we discussed it in our previous talk about low back pain. There are red flags that you have to be, aware about as a physician. For example, in headaches, you have the worst headaches ever, first severe headache. These are red flags that there's something serious going on in the brain. Subacute worsening over days or weeks, abnormal neurologic examination, fever, or unexplained systemic signs, vomiting that precedes the headache, pain induced by bending, lifting, or cough, pain that disturbs sleep or presents immediately after awakening. Also known systemic illnesses, onset after age 55, and pain associated with local tenderness, example, region of temple artery. Management of headaches. I call them the 3 P's and 2 S's: psychological, physical, pharmacological, pain interventions, and surgical interventions. You can extrapolate this for all types of pain, cancer and non-cancer. Psychological, we have biofeedback, relaxation, guided imagery, breathing exercises, and CBT. Physical therapy, such as acupuncture, acupressure, TENS unit, spray and stretch, and osteopathic techniques. This is a picture for biofeedback techniques. They're useful in migraine and tension headaches. Cognitive behavioral therapy. Nowadays, we have also a technique called ACT, or acceptance and commitment therapy. And this is gaining more momentum than the CBT. Acupressure points for relieving headaches and migraines. These are some of the important acupoints that we use for headaches. And I've used all of them. And I want to say something here. When I see a patient, because I have a background of acupuncture, I teach them how to do acupressure. I mean, I wouldn't give needles to the patients and tell them to do acupuncture for themselves. Maybe in certain areas in the world they might do that. Okay, but as far as I'm concerned, uh, this has medical legal liability. So I teach them the acupoints, and I teach them how to do acupressure. And these are very important points that you see in front of you, especially the large intestine 4, the one in the hand here, in the first web in your hand, and liver 3. You can see it in the bottom here, and others. All of these are important points. Chemotherapies. So we're going to throw some questions in. Which of the following patient characteristics is most likely to predict utilization of CAM therapies? The correct answer is previous exposure to CAM. Now, as far as CAM therapy for headaches, the most 3 important products you need to be aware about are magnesium oxide, coenzyme Q10, and riboflavin vitamin B2. Pharmacologic techniques for headaches. We have abortive techniques such as NSAIDs, triptans, ergots, steroids, and prophylactic such as propranolol, topiramate, calcitonin gene-related peptide antagonists, and Botox. Proposed triptan mechanism of action. Triptans work through the 5-hydroxytryptamine 1B/D receptor. Okay, there are 5-hydroxytryptamine 1B/D receptor agonists, and they cause vasoconstriction. Again, migraine is a vascular neurologic phenomenon. Neurogenic inflammation, vasodilatation, and myofascial component. Three components. So with the triptans, it works on the blood vessel. Okay, it causes vasoconstriction, and also it prevents the release of peptides that can lead to neurogenic inflammation. Okay, so we're left with the myofascial component. You can add another medication for that purpose. Triptans. What is the mechanism of action of somatriptan? Selective. The correct answer is selective 5-hydroxytryptamine 1B/D agonist. Proposed role of calcitonin gene-related peptide receptor antagonists in migraine. Recently, we have these host of new medications that work on the calcitonin gene-related peptide, which is basically a mediator that's potent neuropeptide expressed in the trigeminal system, and it actually increases during migraine and cluster headaches. Calcitonin gene-related peptide receptor antagonists may act at multiple sites to block the actions of calcitonin gene-related peptides. They are not vasoconstrictors. Galcanezumab mechanism of action is antagonizing which receptor? Calcitonin gene-related peptide. This is one of the drugs that are anti-calcitonin gene-related peptides, and it has the name of Emgalti in the market here. Galcanezumab. There are a bunch of them. Okay, we're not gonna go through all of these, but there are abortive and there are ones that preventive. like this one on the right here in the lower part, uh, uh, VPT. This is a preventive measure. Okay, so not all of them, and also the upper one on the left, Amovig. Amovig is another preventive. So really, you have to really read the literature, and before you decide which one you're going to use, because you know, there are abortive medications and there are preventive medications. Pain interventions. We have diagnostic blocks for migraine, such as supraorbital, occipital nerve block, trigeminal, sphenopalatine, trigger points, and Botox, neurolysis, such as chemical radiofrequency thermocoagulation, pulse radiofrequency, and cryoablation. Surgical interventions. Surgery has very specific role in headaches, okay? And I put them into these 5 points here. Number one, surgical decompression of the foramen magnum in Arnold Chiari. CSF shunt for idiopathic intracranial hypertension. Surgical closure of dural artery in intracranial hypotension. Microvascular decompression in cranial neuralgias, such as, for example, trigeminal neuralgia. And then lastly is deep brain stimulation in dystonias and um, cluster headaches. This is kind of a nice picture for different types of headache. And I mean, I want to just, you know, um, say something about this picture. This picture shows you the complexity of headaches. Okay, sometimes you see the patient and you're not able to make a diagnosis which type of headache it is. Okay, so be humble about headaches, and if you feel you're not comfortable with the diagnosis, send the patient to a neurologist. Okay, that is specialist in headaches. There's nothing wrong with that. Okay, instead of starting treatments that unnecessary for the patient. Okay, tension headache versus migraine headache. Usually, tension headache is bilateral. Usually, migraine headache is unilateral. Migraine goes into 4 phases: prodrome, aura, pain, and postdrome. Okay, this is a classic type of migraine. There's another type that's called common migraine. Okay, that doesn't have aura. Other migraine variants, we have a basilar migraine, which is basically uh, occurs in children, average age 7 years old. And these guys, they, stool, dizziness, vertigo, visual disturbances, diplopia, ataxia, followed by occipital headache. There's another type called familial hemiplegic migraine. It's an autosomal dominant disease which can cause transient hemiplegia, precedes headache by 30 to 60 minutes. Headache can be contralateral to focal deficits. And then you have post-concussion migraine, which can be acute or subacute, occurs with or without aura. Treatment is similar to conventional migraines. Acute migraine. Another question. Select the correct statement about the use of intravenous dexamethasone for treatment of acute migraine. IV dexamethasone may be effective for migraine persistent for more than 72 hours. Sometimes we call it status migrainosus, old terminology, but some people still use it. Tension type headache. Which one is the most common type of headache? And we mentioned this at the beginning of the presentation. It's tension headache. Which of the following forms of therapy is most effective in preventing chronic tension headaches? CBT combined with TCAs. So this is simple, therapy here, CBT and, TCAs, such as amitriptyline, for example. Myofascial pain disorder. I do believe, that many interventionists, they really underestimate the role of myofascial pain. As I said, headache basically are three components: neurogenic inflammation, um, vascular, uh, and then you have myofascial component. So if you look at this picture from Jeanette Ravel book here, look how many muscles can cause headache, all right? And usually these they get under recognized and they get diagnosed with a different, problem. Botulinum toxin. There are two types, A and B. And this one, botulinum toxin inhibits the presynaptic release of nociceptive peptides. Indications of, botulinum toxin: a history of migraine headaches, headaches including tension headaches on most days, 15 or more of the month, of which 8 are migraine. And by the way, guys, these indications are very important. I remember back in the U.S. when we used to order botulinum toxin, we have to call the insurance and tell them exact diagnosis. Otherwise, they will not accept reimbursement to these patients. The company has put different diagrams in the in the net that you can look it up, and just follow their diagrams for the migraine headaches. Which of the following headache types has particularly successful results from the use of botulinum toxin? The correct answer is migraine. So botulinum toxin has two roles. One of them is inhibiting the release of acetylcholine from the presynaptic region, and also it inhibits, and thus this will cause muscle relaxation. All right. Also, it inhibits the release of the peptides, the neuropeptides, from the presynaptic membrane. So one for myofascial component and the other one for inflammatory component. Trigeminal autonomic cervicals. These are rare entities, but there are, pretty serious. I look at these trigeminal autonomic cervicals as a spectrum, starting from the sunct to paroxysmal hemicrania to cluster headaches. Each of them has, characteristic time frame. So, for example, the sunct is 5 seconds to 4 minutes. The paroxysmal hemicrania is 2 to 30 minutes. Cluster headaches is 15 to 180 minutes. Okay? All of them, they show up with, small pupils, swollen or droopy eyes, reddened conjunctiva, tearing, tearing, and then nasal discharge or congestion. Right? And all of these are autonomic manifestations of this trigeminal autonomic cervicals. So you have to really know the differences between the three of them because the treatment is different. Okay. For example, cluster headaches is more in males, while paroxysmal hemicrania is 1-to-1. And, the SUNT is also more common in males. The type of the pain, stabbing, boring, you're not going to be able to know the difference from the type of the pain because all of them are excruciating pain. They are very serious type of pain, and usually they're localized to the orbit or the temple. Okay, I would say the main difference in the duration of the attack. Okay, as we said, the cluster headaches are 15 to 180 minutes. Paroxysmal hemicrania is 2 to 30 minutes, and SUNT is 5 to 240 seconds. Autonomic features are on the three, conditions. So, what else can you, use to pick up which one is, which type of headache? Again, I said the duration of the headache is very important. Also, the response to indomethacin is extremely important. If the patient is responsive to indomethacin, it would be paroxysmal hemicrania. Okay? Cluster headache. What is the drug of choice to treat acute cluster headaches? Okay? Subcutaneous sumatriptan. Also oxygen. Giving oxygen in a non-rebreather mask for 15 minutes can help with your headaches. So either this or that. Okay. Select the first preventive medication for episodic and chronic cluster headaches. The correct answer is verapamil, which is a calcium channel blocker. Which of the following is true regarding patients with cluster headaches? They are known to attempt suicide secondary to their pain. That's the correct answer. So, as I said, these are pretty serious headaches. They can lead to suicide. So we have some interventions for cluster headaches, such as sphenopalatine ganglion block, which can be done in a very simple way by just putting, a cotton that is, soaked with lidocaine 4%, in the nasal mucosa. All right. And you can do it under X-ray in what we call infrazygomatic approach. And this is if you're gonna, do a pulse radio frequency and all that stuff. But if you're not comfortable with doing the infrazygomatic, please, this is the simplest thing you can do in your life is just putting this intranasal, cotton soaked with lidocaine. Just do it gently. And if you feel a resistance, don't try to go through the resistance. Just let go, okay? And let the local soak the, the mucosa, and it will reach the sphenopalatine ganglion. Which is not routine complication of sphenopalatine ganglion radiofrequency thermocoagulation? Meningitis, okay? Epistaxis can happen, infection can happen, and bradycardia. When you do it, the infrazygomatic approach, be careful. Have atropine, available. Okay, we'll talk a little bit about the SUNT here. Short-lasting unilateral neuralgia form headache with conjunctival injection. Okay, this is called the SUNT. And then there's another one, and tearing. Okay, there's another one similar to it called the short-lasting unilateral neuralgia form with cranial autonomic symptoms, or SONA. They're very similar to each other. The SUNT is basically there is tearing, during the processing. Select the correct statement about, SUNT. Pain attacks usually last 5 seconds to 140 seconds. Remember, it does not respond to endomethacin, and it's more common in males. Another question. Select the effective treatment for SUNT. All right? Intravenous lidocaine. Endomethacin sensitive headaches. Guys, I want to say something. I mean, when I find an endomethacin sensitive headache, this is a good thing for me because I have a treatment for the patient. Unfortunately, endomethacin is heavy on the stomach. So you got to be careful about it. Make sure you cover the patient with PPIs and all of that stuff. But we have, basically 5 different types of headaches that respond, exceptionally to endomethacin. Paroxysmal hemicrania, hemicrania continua, Valsalva-induced headaches such as cough, sexual and exercise-induced headaches, primary stabbing, and hypnic headaches. All right. The last one, hypnic headaches, happens in the elderly folks, which wakes them up in the middle of the night, and usually have a specific circadian, pattern here. Like it comes at a certain time during the night and wakes up the patient. SUNT is distinguished from paroxysmal hemicrania by its response to each of the following medications. Again, same question, endomethacin. Endomethacin works in paroxysmal hemicranias, but not SUNT. Again, SUNT is tearing, ends with a T. Okay, very important. Because there's another one that's similar to it. It's called the SUNA, SUNA. This one doesn't, the patient doesn't have tearing. And thus, you don't have the T at the end. All of these are pretty rare, diseases. But I mean, if you're doing lots of headaches, you will definitely have one of these patients will come by. Another serious problem is ulnar Chiari malformation. Okay, this is a condition where the cerebellum is pushed through the opening in the skull. And we have 4 types of ulnar Chiari. Type 1 is generally asymptomatic, but often manifests with headache and cerebellar symptoms. This is the one that I've seen in my practice. There's type 2, which is usually accompanied by meningomyelocele or myelomeningocele, leading to partial or complete paralysis below the spinal defect. Abnormal development of the cerebellar vermis and medulla occur, and they both descend into the foramen magnum. Hydrocephalus is also nearly always present. So this is a pretty serious type of ulnar Chiari. And of course, it needs surgical intervention. Type 3 causes severe neurological deficits. It's associated with omphalocele. Type 4 involves the failure of the brain development. Again, this is one of the few conditions of headaches that you might need surgical intervention if the patient is basically symptomatic. And most of the time, you're going to see type 1 in your practice. You're not going to see the other types. Chronic daily headaches. The commonest two types of chronic daily headaches are chronic tension and chronic migraine headaches. Okay, and in these circumstances, the episodic headache turns to a continuous one, to chronic daily headache, and usually it's related to abuse of the pain medications, the abortive pain medications, such as, NSAIDs, acetaminophen. I mean, literally all the medications, if you overuse them, they can turn your headache, from an episodic to chronic. And thus, in these situations, you need to cut off the short acting and give more of the preventive measures. Medication overuse headache, secondary chronic daily headache, headache induced by the overuse of analgesics, as we just mentioned, okay? Triptans or other acute headache compounds, all right? Repeated medication reaches a threshold causing transformation. So this is medication overuse headache is a type of chronic daily headache, but it's a secondary type because it's, there is a cause that we can see. So once you have a patient, whether it's a migraine or tension, you need to ask them about the use of their analgesics here. Preventive agents used in treatment of chronic daily headaches. Again, you have to use more of preventive measures in patients with chronic daily headaches and less so with abortive medications. So we have different medications such as amitriptyline, topiramate, propranolol, gabapentin, riboflavin. There's a study for riboflavin, but it's a higher dose than the usual daily intake that you use, in your like in your multivitamin. I don't know the number, but this is a much higher dose. You need to take around 200 milligrams twice a day. And then verapamil for cluster headaches. Of course, this verapamil, it's a calcium channel blocker. It can cause constipation and dizziness. And you have to follow the QT interval on EKG. The topiramate, by the way, can cause, renal stones, and it can cause increased, intraocular pressure. So you need to warn the patient about these two things. If they start to have like a flank pain or, visual disturbances, they need to stop the medication. Propranolol is a beta blocker, non-selective beta blocker. So sometimes it causes occasional exercise intolerance, asthma, and nightmares. Gabapentin can cause lethargy, and sometimes it causes non-pitting edema. B12, B2 can cause upset stomach. Cervicogenic headaches are headaches that are related to, the neck or the cervical spine. All right. And basically, these are the four causes of cervicogenic headache. Atlanto-occipital joint, can cause headaches, cervicogenic headaches. Atlantoaxial, C2C3 zygophyseal joint, and C2C3 intervertebral disc. So you need to memorize these four causes of cervicogenic headaches. And of course, you can inject, in the joint, the atlanto-occipital and the atlantoaxial. But these joints, you cannot have an access to the nerves that's supplying them because they're coming from the venter ramus. So you have to inject the joints themselves. But as far as the C23 zygophyseal joint, you can inject either the joint or the nerve that's supplying the joint, okay, which will be basically the third occipital nerve and the C3 medial branch. And of course, if it's a C, 2, 3 intervertebral disc, you can do an epidural steroid. If you do an epidural steroid, you can thread a catheter and you can reach this area and put some steroids there. It's not a common site for herniation, okay? But for the sake of completion, I just wanted you to know about it. Literally, you cannot put a needle above C6-7 when you do a cervical epidural because the dura is attached to the bone and you can easily get into the spinal cord. But you can thread the catheter or you can just inject and usually it will reach up there. Put enough volume there. And this is just to show you, a frontoaxial and third occipital nerve block. With the third occipital nerve block, you have to do it at 3 levels. Okay, normal values for CSF. Opening pressure is 50 to 200 millimeter water. Okay, this is important to know these numbers, guys. And it's usually colorless, crystal clear, with very few mononuclear cells. Total protein is somewhere between 22 and 38. And glucose is 60 to 80% of blood glucose. Mono-Kelly doctrine is a very important physiological concept. And basically, it's what it's saying is that the skull is a rigid container and it has 3 components, basically brain tissue, CSF, and blood. If any of these increase in volume, okay, since this is a rigid container, the skull, it will push on the other components in your brain. So if the CSF, goes up, it will push on the blood and can cause ischemia. And vice versa, if you have an intracranial bleed, you will reduce the CSF. So some of the applications of the Monro-Kelly doctrine is spontaneous intracranial hypotension. And this is very similar to the headache you encounter from, a dural puncture when you're doing your epidural, injection. But it can happen spontaneously without putting a needle, okay? And the incidence is somewhere between around 5 to 100,000. Women are affected more than men. The hallmark of this spontaneous intracranial hypotension is basically postural headache, blurred vision, tinnitus, but it has to be postural. If the patient sits up, the patient starts to have the headache. All right? The headache could be diffuse, localized to temporal, frontal, or more commonly occipital. And management is you can try sphenopalatine blocks, you can try occipital blocks, you can try a blood patch, and type 3 and 4 leaks, you have to consult your neurosurgeon colleague, okay, to basically repair the leak that's going on there.
Spontaneous intracranial hypertension. Radiological signs for spontaneous intracranial hypertension include sagging of brain, downward displacement of tonsils, and subdural fluid, 72%. Correct. Pituitary enlargement. Correct, 57%. Pachymeningeal enhancement. Look at the picture. All right. All of these in 33% of the cases. All of these are pathognomonic for spontaneous intracranial hypertension. Then we jump in one of my favorite topics is the idiopathic intracranial hypertension. All right. We use a criteria called Dandy's criteria. This criteria is so important. I just had a patient with idiopathic intracranial hypertension, a young girl, 12 years old, that had symptoms of raised intracranial pressure, headache, nausea, vomiting, visual, abnormalities, and papilledema. Usually there is no localizing sign except maybe the abducer nerve pulse or the sixth nerve pulse. Usually the patient is awake and alert. And if you do a spinal tap, the lumbar pressure, opening pressure will be more than 25 centimeter water. Okay, and normal biochemical and psychological composition of CSF. And no other explanation for the raised intracranial pressure. These are the Dandy's criteria. You got to really, learn these because one of these days you're going to see these patients. Management is low sodium diet, weight loss, okay, at least 10% if the patient is obese. Diamox, optic nerve sieve fenestration, where they this is the last resort type of surgery, okay? And this is done by ophthalmologists, where they kind of create some sort of a sieve around the optic nerve to decompress the optic nerve. Repeated lumbar punctures, but of course, eventually you have to do something more permanent. So you do a CSF shunt. Nowadays, they have also a venous stenting to some of these vessels. They found that, after doing like an angiogram, they're capable of picking up the vessels that are, stenosed, and they put a stent, and this reduces the pressure. Okay, something similar to like if you have a heart attack, right? So you put the contrast, and then you look at but this is venous, okay, not arterial. So this is another recent addition to the ones that I just mentioned. But the optic nerve fenestration is usually, at the end of the list here. And sometimes, as I said, you have to do a shunt, okay? And usually the shunt is basically, lumboperitoneal shunt. And this is done by neurosurgery right away. Idiopathic intracranial hypertension, or sometimes they call it the old name, pseudotumor cerebri. Lumbar puncture is sometimes therapeutic for which diagnosis? Okay, the correct answer is pseudotumor cerebri or increased intracranial hypertension. Giant cell arthritis or unilateral temporal headache associated with polymyalgia rheumatica. This is basically will show up as vision loss, jaw claudication, anorexia, weight loss, fever, and thickened vessels. Steroids followed by temporal artery. The treatment is basically it's an emergency. You have to give high dose steroids, prednisone. Okay. and you have to do a temporal artery biopsy. Otherwise, the patient will, lose vision. The steroids are utilized for 1 or 2 years, guided by the SAD rate and clinical symptoms. This is a rheumatic disease, giant cell arthritis. Temporomandibular disorders, and this is really a common thing that we see in practice. Okay, temporomandibular disorders can give you a variety of symptoms, including headaches, earache, shoulder and back and neck, can be stiff and tired all the time. I mean, it can affect your teeth, can affect your jaw. You get this clicking, popping in your jaw joints. You get pain in the cheek, limited opening, face pain, muscle stiffness. The best way to deal with this is to do temporomandibular joint injection under ultrasound. Okay, it's a super simple injection under ultrasound. Otherwise, under X-ray, it's pretty difficult to do. Okay. Sinus headaches. So you can start with steroids, and you can also do PRP. If it's you're thinking about repairing the joint itself. As you can see here, the mandibular condyle and the articular capsule, masseter muscle, all of these, under ultrasound guidance. Sinus headaches was, or sinusitis is overestimated somewhat. Okay, most of these sinus headaches are migraine headaches, by the way. But I mean, not all of them, of course. There are sinusitis, chronic sinusitis in some patients. And you should get a CT scan, for these folks that you're suspecting sinusitis, to make sure it's a sinusitis diagnosis, not migraine, because the treatment here is totally different than sinusitis, which is basically using decongestants and antibiotics and all of it. Atypical facial pains can happen in ladies, okay? And basically, these folks, they give you vague symptoms, okay? First, you might think this is trigeminal, this, that. But one nice, point, if the patient headache, okay, focus here. If the patient headache gets better if you by scratching the area of the pain, this is usually atypical facial. Because like trigeminal patients, cannot touch this painful areas, or if they touch it, it hurts like hell. But if the patient tells you, if I massage this area, the pain gets better, this is not, a neuralgia. This is atypical facial pain. And usually these patients respond well to tricyclic antidepressants. Cranial neuralgias. We have neuromas, trigeminal neuralgia, glossopharyngeal neuralgia, sphenopalatine neuralgia, postherpetic, and geniculate neuralgia. Okay, so neuromas could be related to a skull fracture. And we have 3 types of skull fractures here. Lefor 1, Lefor 2, and Lefor 3. And if one of these nerves get affected, you might need to inject it with some local and steroids. And basically, these are the nerves might be in your way here, like a mental nerve, infraorbital, supraorbital. They are all in the same trajectory here. Trigeminal neuralgia. The incidence of trigeminal neuralgia is 4.3 per 100,000 persons per year, with a slightly higher incidence for women compared with men. And the pathophysiology is basically focal demyelination of the trigeminal nerve, often from vascular compression prior to entry into the pons. A classic feature of the trigger zone is that stimuli are normally innocuous, are sufficient to activate a painful episode. Brief unilateral paroxysm of electrical-like pain along the trigeminal distribution. I like to ask this question: which artery that's usually pushing on the trigeminal? It's called superior cerebellar artery. Trigeminal neuralgia of different types. We have the idiopathic, which is basically type 1 and 2, okay? And then there's one that's related to a trigeminal injury. We call it trigeminal neuropathic pain or trigeminal deafferentation pain. If it's associated with MS, we call it symptomatic trigeminal neuralgia. If it's related to shingles, we call it post-herpetic trigeminal neuralgia. So we have symptomatic trigeminal neuralgia, either multiple sclerosis or tumor at the cerebellopontine angle. In multiple sclerosis, trigeminal actually neuralgia affects 2 to 5% of patients with MS. Okay? The treatments medication management, most famous is Tegretol or carbamazepine or its cousin, oxycarbazepine as a first choice. Second choice is baclofen. Also, you can do a Gesserian block, okay? You can do radiofrequency ablation, glycerol ablation, balloon. You can use a balloon to and inflate it in the, trigeminal ganglion. You can also inject the nerves coming out of the trigeminal, the maxillary and the mandible. We don't have an access to the ophthalmic itself, nerve. However, we can inject the branches of the ophthalmic nerves. Okay, a 76-year-old woman with intense paroxysm of unilateral electrical shock-like pain in the face. That's usually triggered by brushing her teeth or washing her face. Which of the following is the best initial management? Again, administration of carbamazepine or its relative oxycarbazepine. Oxycarbazepine has the advantage that it doesn't, cause drug-to-drug interactions. Okay, it doesn't cause, a pancytopenia and liver toxicity like carbamazepine. So it's really a nicer, alternative. And some authorities consider it now the first choice. Okay, but both of them can cause hyponatremia, by the way, low sodium. So you gotta be, monitoring this. Botox for trigeminal neuralgia. Okay, in this situation, we inject the terminal branches of the ophthalmic, maxillary, and mandible. We call them the trigger zones. Trigeminal neuralgia surgeries. We have microvascular decompression, which is very successful, especially if you're you prove that there is a pressure on the trigeminal ganglion. Also, gamma knife radiosurgery is an important way to, treat trigeminal neuralgia. And lastly, rhizotomies, such as glycerol injections, balloon compression, and radiofrequency thermal lesion. As a pain interventionist, this is the one that we do. I mean, radiofrequency, either conventional radiofrequency or pulse radiofrequency. Glossopharyngeal neuralgia. This is a rare entity, but I've seen few of these in my practice. Usually, it comes with a unilateral pain along the glossopharyngeal distribution. Swallowing, coughing, yawning, and talking can trigger pain. Patients can have syncope, dysrhythmias, seizures, and mediated through vagus. And that's why this type of neuralgia is more serious than trigeminal, because it's associated with syncope and dysrhythmia. It could be fatal, okay, and seizures. Eagle syndrome is a variant of glossopharyngeal neuralgia, where the pressure of the glossopharyngeal caused by elongation of the styloid process or calcification of the stylohyoid ligament. And you can inject this one. Herpes zoster pain, usually in patients above 65 years old. Okay, 75% of the cases above 65 years old, and usually affects the ophthalmic division of the trigeminal. In these situations, we do a stellate ganglion block, okay, because the shingles, acute shingles, is a sympathetically mediated pain. We have a question here. During the stellate ganglion block, a patient becomes restless, tachypnic, disoriented immediately after receiving a test dose of local anesthetic. Which of the following is the most likely cause of these symptoms? And the answer is vertebral artery injection. Ramsay-Hunt syndrome, okay, is another shingles or herpes zoster type of pain. It comes with a vesicular rash on the external ear, lower motor neuron, paralysis of the facial, loss of taste over the anterior two-thirds of the tongue. And this one is related to herpes zoster of the geniculate ganglion of the facial nerve. This guy on the lower part of the picture, he's a famous Canadian singer. I think his name is Justin Bieber or something. And basically, he actually got affected with the Ramsay-Hunt syndrome and, got the symptoms. So there's something also similar to, shingles, Ramsay-Hunt syndrome, called the nervous intermedius neuralgia or geniculate neuralgia. It's similar to Ramsay-Hunt, but it's not related to shingle. Okay, so you don't get these vesicles around the ear. So geniculate neuralgia occurs when the nervous intermedius nerve is compressed by a blood vessel. The pain is usually described as an ice pick pain in the ear, but can also be dull or burning. Some medications are available for treatment, but it might also need microvascular decompression. So if you seem like trigeminal neuralgia here, okay? Occipital neuralgia. Symptoms of occipital neuralgia. Occipital pain that may or may not be limited to one side, pain radiation from the back of the head into the sides, and finally into the temples and cheek and forehead, pain above and behind the headache at the eye, severe light sensitivity, nausea when pain is severe, pain radiation to the ear, shoulder, and at times the arm. You can inject the occipital nerve, the distal approach or proximal approach. The distal approach, it's very simple. You draw a line between the occipital protuberance and the mastoid, and basically, you choose the middle third in the subcutaneous area and inject the occipital nerve. So this area is pretty safe. But if you're planning to do the proximal approach, this is below the occiput. So you have to use an ultrasound because you cannot go deep. You can get inside the, epidural space, or you can get inside one of the, vessels going to the, to the cranium, like the vertebral artery, for example. And also you can do nerve stimulation if it's intractable case. By the way, we do a lot of occipital and supraorbital nerve blocks for migraine headaches. This is like a routine. So when I have a patient coming to me with migraine, intractable migraine, I do 3 types of blocks on it: supraorbital, occipital, and sphenopalatine. Not necessarily all of them in the same day, but we can combine 1 or 2 at the same time here. Tolosa-Hunt syndrome. It's a rare pathological condition in which affected individuals experience severe periorbital headache along with ophthalmoplegia, usually in one eye. These symptoms, in the majority of the cases, resolve on their own without any intervention, but then again recur. How about brain tumors in adults? Well, usually presents with a non-migrainous chronic headache, can also present with partial complex seizures and focal neurologic signs. Okay? Headaches in children. Of course, in these situations, we give steroids, okay, and anti-seizure medications if the patient develops seizures. But if the patient doesn't develop seizures, you don't have to do prophylaxis with anti-seizure medications. And of course, you need to refer the patient to your neurosurgeon colleague. Headaches in children. Which of the following statements are true regarding headaches in children? Always search for organic causes such as viral infection, head trauma, brain tumor, and meningitis. Migraine equivalents are more common in children. Hemiplegic migraine begins in childhood and generally ceases in later life. All of the above. Key learning point. First, you have to figure out whether this is a primary headache or secondary headache. All right? As we said, there are 3 causes in the pathophysiology of headaches in general. Neural, or central, such as trigeminocervical, thalamus, hypothalamus in case of cluster headache, for example, okay, and cerebral cortex. Or could be vascular, such as the dural sinus, meningeal vessels, and it could be myogenic. And I stressed on this point in this presentation. Many, unfortunately, interventionists undermine the role of myofascial pain syndromes in, producing headaches. The headache could be nociceptive, inflammatory, like calcitonin gene-related peptide, prostaglandins, substance P, 5-hydroxytryptamine, and so forth. Or it could be neuropathic. So we have three types of physical pain here. Also, it could be non-physical pain. And we call this whole picture total pain. This is basically, in a nutshell, what headaches about. If you think systematically, like I put it to you here in this slide, you'll be able to deal with most types of headaches here. ICHD 3 is my reference in this presentation. Thank you.